Hi, everyone. So I'm Mark Swain. I'm a liver specialist, as Mike said, and I've actually known Mike for at least probably 25 years, right? Yeah. And
Maybe longer.
and maybe longer, yeah. And it's like, I can't give enough credit to Mike because the Fatty Liver Alliance, basically, there was no advocacy really for fatty liver disease in Canada. And he started it from nothing, essentially. He, because of his family and his own personal experiences with fatty liver disease, he just decided to start Fatty Liver Alliance, and it's gone from nothing to an amazing thing. And so it just shows you what one person who's driven and has passion, what they can do. And so I give him a lot of credit for this. So I'm going to talk tonight about, I'm just going to give you some background about fatty liver and kind of how it forms, what it does, why it progresses. I'm going to talk about some of the exciting stuff that's happening with regards to treatments, because it's come a long way very quickly, and it's going to go a long way very quickly in the near future. So there's a lot of exciting stuff happening in the world of fatty liver with regards to therapies. Next slide. So when people are talking about fatty liver, this slide kind of shows you what it is, okay? I don't have a pointer, so I'm going to walk over here and show you. So these are normal liver cells, and the normal liver cells they're like cinder blocks, like for concrete blocks. And they're these little blocks, and they're all piled in these long chains, and the white parts in the middle, that's where the blood flows through the liver, all right? And so what happens with fatty liver is you have too much fat coming to the liver and not enough leaving the liver cells. And the liver cells are normally don't have any fat in them. They're this little block here, but here you can see what they do is they get full of fat and they swell up like balloons. And so this is a liver that's got quite a bit of fat in it, because you can see all these cells the insides have been replaced with fat. Next slide. And when you go and get an ultrasound, people can pick this up on an ultrasound. So up in the upper left there, that's a normal liver. And the liver kind of is this part up here where it has a blue thing and that sort of thing up in the upper left. And you can see it's sort of a darker color. And as it gets more fat in it, it becomes lighter. Okay, it becomes what's called more echogenic, which means it bounces the sound wave off. So if you look at the upper right one, it's whiter, right? And you look at the bottom left, it's even more white. And it's even more white, and you start to lose the ability to see the back of the liver here. So if you were looking for say, a cancer or something in the liver or something abnormal, you can't see it. So the ultrasounds become less effective at looking through the liver when you have fat in it. Of course, when you have even more, you can't even see the diaphragm, which is here. You lose it completely. So you lose the ability to look through the liver. But this is how they say, when you get an ultrasound report that says fatty liver or steatosis in the liver, this is what they're looking at. This is how they're grading it. Next slide. So what causes fatty liver? So there's really two main causes, alcohol and non-alcohol, really. So once you move away from alcohol and you're dealing with non-alcoholic fatty liver disease, it's really essentially obesity and diabetes are the main drivers, essentially. But all these other things, so the fats in the blood, like high cholesterol, high triglycerides, I'll get into it more later, medication, things like that, they can all do that, but these are the two main drivers, obesity and diabetes. Next slide. And so when people started out with this concept of non-alcoholic fatty liver disease, I'm going to talk about the name change as well, but really the idea was, it was a diagnosis of exclusion, because alcohol and these other metabolic drivers can cause fatty liver, so you had to exclude alcohol, and that was done by history. So if a man was drinking more than 3 drinks a day, or a woman was drinking more than 2 drinks a day, then they were moved out of non-alcoholic fatty liver disease and automatically put into alcoholic fatty liver disease, which is obviously stigmatizing and has other issues, which I'll get to. Next slide. And so this whole concept of people coming with abnormal liver tests to see their doctor and being told, how much do you drink? And they say, well, I don't drink. And they say, no, how much do you drink? And over and over and over again, it became a very stigmatizing issue. It still is. Everyone that comes and sees me as a hepatologist, I do see fatty liver, but I see many liver diseases. They've all gone through this process of being told, how much do you drink, over and over and over again. Next slide. So the reason why the name has changed, and the name has changed, like, Non-alcoholic fatty liver disease is actually quite easy to say, and I think people are pretty comfortable with it, but because of these issues, people felt there needed to be a change to remove some of these issues related to stigmatization. So they wanted to get rid of alcohol, and they really wanted to essentially find a definition that had positive criteria. It wasn't that you were trying to exclude alcohol, but you had to have positive criteria. And they also wanted to remove the word fatty. And this is where a bunch of hepatologists got together and decide on this name, metabolic dysfunction associated steatotic liver disease, which no one can say, of course. So people just say MASLD, right? So I think MASLD is a reasonable short form. I still fluctuate between NAFLD and MASLD, but eventually it will become MASLD, and MASH is the other name, which I'll get to. Next slide. This is what the liver does, and Liam will show you with the model later, is that when the liver gets full of fat, so I showed you on a microscopic level at the beginning, but this is what it looks like when you look at the whole liver, all right? It gets kind of swollen and bigger, and it gets yellow discoloration like you would see when you look at bacon or whatever, right? That's fat, right? And essentially, it's a marker of metabolic derangement in the body, all right? And so it's associated with something called the metabolic syndrome. You may have heard about that or whatever, but really it's the liver manifestation of metabolic syndrome. Next slide. And this is the metabolic syndrome, all right? It's a bunch of stuff that happens in the body where the liver is just part of that, okay? So it's insulin resistance, so it can be diabetes, or people can be told by their doctor that they have pre-diabetes, so that means they're almost at diabetes, but not quite. High blood pressure, high triglycerides, which is a fat in the blood that everyone's familiar with cholesterol, but people aren't so familiar with triglycerides, but that's the other fat in the blood, which is more commonly associated with fatty liver. Low HDL cholesterol, so HDL is the good cholesterol, so you want it to be as high as possible. So as it goes below 1, the number, just number 1, then you get your heart risk and your other risks of the metabolic, that's a metabolic syndrome. And then something called visceral obesity. Next slide. And so what is visceral obesity? Okay, so there's really two types of fat accumulation in our bodies. There is where you gain weight below the belly button, so pear shape, or when you gain it in the middle, which is called apple, all right, or apple shape. So this type of fat, so when you gain it on your bum or your lower body or your legs, it's actually less metabolically active. It just sits there, and it doesn't generate stuff that drives the metabolic syndrome quite as badly. When you have the fat in the middle, which is visceral, and the reason why it's called visceral is because around all of our organs in our middle. So our liver's in there, kidneys in there, pancreas, all that stuff gets sort of fat around it, and it generates all kinds of stuff that makes our bodies have inflammation in them, essentially. And it's a real driver of metabolic syndrome. Next slide. So basically what happens in the body is you eat food, and our pancreas makes insulin. That's kind of how we deal with that. So insulin allows our body to absorb the sugar into our muscles and all the different parts, and we use those sugars for energy, essentially. But what happens is, as usually associated with obesity or overweight, is these cells in our body start to become resistant to effects of insulin. So the insulin levels go higher, but it's less effective. And so because we have all that sugar floating around, we actually start to store it as fat. And so when we store it as fat, that's when we start to essentially get fatty liver as part of that component. And then you start to feel tired and hungry, you eat more food, and it becomes this cycle, essentially. It's important to recognize that if someone is told that they have fatty liver disease or MASLD, and they don't have diabetes, if you follow them for 5 years, they have a 1 in 5 chance of developing diabetes. So they're very tightly associated. So people with fatty liver are at risk of developing diabetes. Next slide. This is the new nomenclature. So the old nomenclature, as I mentioned, it had NAFLD on the left, and ALD is alcohol-related liver disease on the right. And there was a hard red line that when you went over a certain amount, you were into alcoholic liver disease, and that was it. You were no longer in non-alcoholic fatty liver disease. Whereas this new nomenclature, which is MASLD, it actually allows you to consume more alcohol and be part of what's called MET-ALD, which is metabolic alcohol-related liver disease. And so it's a mixture of the two. So it's not an exclusive thing. It's more of a spectrum, which is the reality of the world we live in. So more people are included in this than in that, and there's not this arbitrary thing where people say, well, you have alcoholic liver disease because you're 1 over a day or something like that. Next slide. And so often people will get an ultrasound, or nowadays when we can look in Connect here in Alberta, you can look and read your own reports, and it says severe steatosis. And so patients look at that, and actually a lot of family doctors look at it and they freak out. They think, okay, severe, that's got to be bad, right? Well, it's not bad from a liver point of view. Like, severe steatosis doesn't mean you have severe liver disease. What it means is that you have more metabolic derangement and more metabolic syndrome driving it. It's not that your liver disease is worse, okay? So if you see that, it's not saying that your liver is really damaged or you have a real problem with your liver. It's telling you that your metabolic issues are quite significant. Next slide. And so the idea is to use this new term to develop precision medicine. I'm going to talk about how, you know, it's interesting because a number of years ago, it would just be diet and exercise and then don't come back and see the specialist sort of thing, and which isn't really precision medicine. And so the whole world of treating this disorder has changed dramatically, and it's really shifting into precision medicine, which I'll tell you about briefly. Next slide. And so as Michael said, MASL's very common. Like, so in Canada, probably now it's about 30% of the population has MASL. And if you look worldwide, it's about 40%. As you go in the United States and you go more into the south, it's probably 55% of the population. So it's extremely common. And then about 2 to 3% have something called MASH, and I'll tell you what that is. It's a part of the spectrum of MASL. Next slide. And why do people get it? Well, because we're bombarded with things that are sweetened with things that are really bad for us. So when you look at pop is it's sweetened. So one of the sweetest tasting things that we can sort of ingest is high fructose corn syrup. And they use it in everything because it's so sweet. And humans love sweet tasting stuff. And so anything you get that's really sweet often has this in it. And so pop is the classic example. And so pop is very toxic to the liver. Pop will drive the fat to accumulate in the liver, and it'll drive liver toxicity. And I have lots of patients who have their liver disease mainly driven by pop. Okay, and if they stop the pop, it can have a profound improving effect on their liver. The foods that we often like to eat because they taste great, and as humans we like to eat things that are calorie dense because we're programmed to ingest those because. And most of the human existence was we couldn't get that. So anytime we could get it, we ate it. And so the problem is if you go to McDonald's, you're not getting anything that's going to be not calorie dense. So we're bombarded continuously by things that we're tempted to eat that are high calorie. And then of course, as our jobs that are often nowadays are not physical. They're more sitting at a desk or whatever. So we don't burn off the calories that we used to burn off. Next slide. So when you look at, as I mentioned, if you look at obesity rates and people living with overweight, I mean, this is old data, and you can see that in Alberta, it was about 20% of the population would have been classified with a BMI above 30. That number is quite a bit higher now. Next slide. And directly paralleling that is this yearly increase in diabetes. They go hand in hand, okay? And as I mentioned, if you have fatty liver, you're more likely, in the next 5 years, you're going to develop, you have a 20% chance of developing diabetes. Next slide. And so fatty liver by itself, as I mentioned, so you have this, you're looking at your ultrasound report and it says severe steatosis. That doesn't mean you have severe liver disease, and that doesn't mean you're ever going to get severe liver disease, right? So when does fatty liver turn bad? And really, as Liam will show you later, and I recommend that you look at those model because it's quite striking. When it starts to turn bad, it really does turn bad. Next slide. And so what happens is that for some reason, some people accumulate this fat in those liver cells. So those liver cells swell up like a balloon, like I showed you on that first slide. And what happens in most people is the cells just get bigger, and then when say someone loses weight or gets put on a drug like Ozempic or whatever, the cells just shrink back to close to the normal size, there's no damage that's being done to the liver. The liver is just fine. You do that over and over and over again, right? It's like fat going into a muscle, like around a muscle. If you lose the weight, it goes away. It doesn't. The muscle's still there, still working fine, right? So the liver, for most people, that's what happens. But in some people, what happens is the fat it becomes toxic. It's called lipotoxicity, which just means fat toxicity. And they start to attract immune cells, which are these sort of darker colored cells here. And those immune cells are a component of killing and mopping up dying or dead liver cells. And then you can get something called liver cell ballooning, which is this cell here, which is actually a classic finding that pathologists would look for on a liver biopsy, because that tells you that liver cells are dying in this liver. And it's often associated with abnormal liver tests, but it doesn't have to be. And then what's really concerning is because the liver can regenerate. You can cut the liver in half and it just grows back. So if those cells are dying, but the liver can keep up with that, it'll do that forever. It doesn't care. So your liver can keep doing that. But if it can't keep up, then it heals itself by scarring. And so this blue stuff is scarring. So it starts to lay down the scar tissue in the areas where the liver cells used to be. And as you get more and more of that, and you get enough of it, as Liam will show you with the model, that's when you start to, if you get enough scarring in your liver, that's what cirrhosis is. Next slide. And so this is the spectrum. It goes, most people would just have simple fatty liver. Then if they start to get inflammation, a bit of scarring, this is called MASH. And if they start to get too much scarring, like this, you can see these bands of scar tissue are now surrounding liver cells, making a nodule. The liver that's what we call cirrhosis. That's lots of scarring, so you get nodularity of the liver. Next slide. And when people develop fatty liver, even if they get a bit of scarring, so they're over here, and Liam will show you in the model what that kind of looks like, these people seem to do fine in the long run for a very, very long time. It's only when they get to about here in scarring, which is kind of like the moderate scarring level, where there starts to be a problem, because those people are the ones that progress. So all of the systems that are designed to pick up people that are at risk from a liver issue are really looking for people that are beyond that in this red box, because those are the people that are at risk of progression. And once you get to cirrhosis, these are the people that can progress to liver failure, so yellow eyes and fluid in the tummy and liver cancer. But once you get to here, about a 3 to 4% chance per year of getting a liver cancer. Next slide. So we want to stop people from getting there. So when you think about, now I'm going to turn to treatments, okay? So the typical treatments for years were targeting the components of the metabolic syndrome, which is still the foundation of really what we're trying to do in this syndrome, which is really trying to improve the metabolic syndrome, because that improves overall health, not just liver health. Next slide. And so it's always important, because typically if you went to a hepatologist, they'd focus on your liver. If you went to an endocrinologist, they'd focus on your diabetes. If you went to a nephrologist, they'd focus on your kidneys. That's just the way the medical system works. But it's important to recognize that this is something that affects your whole bodies. So for global health, you have to address diabetes. You have to make sure your sugars are as well controlled as they can be. If you have high cholesterol, because most people with fatty liver disease are going to die of heart disease because of the metabolic syndrome, not from liver disease. It's important to control that cholesterol. So statins, a lot of doctors were frightened of using statins in people with fatty liver disease because they had liver disease. On the label says do not use in liver disease. That's not fatty liver disease. People who have fatty liver disease should be on a statin almost always. They're very effective drugs, okay? Treat high blood pressure, of course, because stroke and heart attack come from high blood pressure, right? And then, of course, weight loss strategies are really geared around, and Wendy will talk more about this, about low carb and low fructose, so avoid fructose. So every diet that's created, pretty much, are all built around low carb. They just have different names and they have different trends, but they're all built around low carb. So anything that you can reduce your carbohydrate intake is going to be beneficial to your liver and metabolic syndrome. Next slide. So as I said, Wendy's going to talk about this later, but really, so that when you look at a diet, you're looking at if you can get weight reduction in the 7 to 10% of range of your body weight, you actually can start to reverse scarring in the liver. You improve inflammation, you can start to reverse scarring. So you can do amazing things if you can do this, but this is hard to do, right? Very hard to do. But it's low carbs, fructose. If you can cut out pop and just drink diet pop or Coke Zero or whatever, it'll make a world of difference. Mediterranean diet is felt to be probably the healthiest globally. And then coffee is in epidemiological studies has been suggested to be beneficial for fatty liver. 2 to 3 cups a day kind of thing. Next slide. So if you like coffee, it's good for you. What about drug treatment? So this would have been a blank slide, like not that long ago, just a few years ago, but it's changed dramatically, and it's going to change even more over the next few years. Next slide. So what about, I'm going to start off with there's 2 key concepts about treatment of fatty liver disease. One is with drugs. One is liver-targeted therapies, and one is targeting the whole body. All right, so I'm going to talk about the liver-targeted therapies first. Next slide. So when people are talking about therapies that are specifically targeted at the liver, they're really talking about targeting scarring in the liver. Okay, and so coming back to that thing I showed you, kind of moderate scarring or above, but currently short of cirrhosis. The therapies are still in clinical trials for people who have cirrhosis. But in this middle section, so kind of moderate to moderately severe scarring, those are the people that are typically targeted by these therapies that are specifically focused on the liver. Next slide. And I'm going to talk about this drug. It's called resmetirom. Okay, this is a drug that has really changed the scene very recently. I'll tell you how recently. And it's probably going to be the first liver-targeted therapy available in Canada. Canada, unfortunately, lags behind probably the rest of the world in drug approval. So I'll tell you a bit about where this is approved and where it's going to be approved. And I wish I could say it's going to be approved in Canada next year, but that's not going to happen. It'll probably be a few years at least. Next slide. So where did this drug came from? People whose thyroid glands are not working properly, they gain fat in their liver. And people have known that for an association. You treat their thyroid disease with Synthroid or medication for your thyroid that's malfunctioning, the fat goes out of your liver. So they've known that. And so actually a company called Roche had this drug for years, but didn't know what to do with it. And so 2 people at Roche said, we will take this drug, we'll buy this drug from you, and we'll develop it. And so they were kind of in a small, very, very, very small company developing this drug. Next slide. And so when you look at how the thyroid works on the liver, it works on something called thyroid hormone receptor beta. And a receptor is just when things float in the body and they cause the cells to react, they bind to something on the surface of the cell called a receptor. So basically, this is a receptor for thyroid hormone that exists pretty much only on your liver, this type of beta receptor. And when people with fatty liver disease, their expression of this receptor on their liver goes down. No one really understands why. And so the idea is that when you would give thyroid hormone to people with hypothyroid, it stimulates this receptor and the fat goes down. But so could you develop a drug that just stimulates that receptor? Next slide. And so they did. And this drug is called resmetirom. I don't know if many of you have probably heard of the New England Journal of Medicine. It's quite a good journal. This was just published in February of 2024. So this is right hot off the press, all right? And this is the results of what's called a phase 3 study. So studies when they come out are phase 1, just is this drug safe? Phase 2 is what dose should I use of this drug? And phase 3 is I'm going to treat enough people so that places like the FDA and Health Canada will say this drug could be approved because it's effective, all right? So phase 3 is the last thing you do before you try to get a drug approved. So they treated people with NASH, or MASH now, who had that middle of the range fibrosis or advanced fibrosis, but no cirrhosis. Next slide. And so they basically took these people, so from about here to about here, so 4 is cirrhosis, okay? So they didn't treat anyone cirrhosis, although they are now in clinical trials. Next slide. And they gave placebo, because these drugs have to be placebo controlled. I'll show you why, actually, why they have to be placebo controlled. And they gave 2 doses, 80 or 100 milligrams as a tablet per day. Next slide. And what they found is, so that inflammation in the liver that I showed you, that inflammation is called NAFLD activity, or NASH activity. And so if you look at placebo, about 14% of people with no drug improved. But 25% of the people getting this drug had that inflammation go out of the liver. It resolved completely with this drug. Next slide. But the exciting thing, which is actually has dropped out of this somehow, is that a number of drugs had shown an improvement in this inflammation part, but they couldn't show an improvement in the scarring part. This drug actually showed an improvement in the scarring part. So people shifted from seeing, say, a 3 out of 4 to a 2 out of 4. About double the number of people in the treatment group compared to placebo, about a third of people. Next slide. Broadly, the drug was pretty well tolerated. You can see diarrhea, nausea more common in this medication. But serious adverse events were no different than placebo. So it was pretty well tolerated. Next slide. And so this drug was just approved by the FDA to be used to treat people that have 2 or 3 out of 4 scarring in the liver with NASH. This is the first therapy that has been approved for the use to treat this, and the target is to make the scarring get better. As I say, it's not available in Canada, and hopefully it will be within 2 years as our system here works. Next slide. But it's exciting times, I think. I'm going to shift away from that, which is a liver-targeted therapy, to talk about holistic therapies, okay? So this is the idea of treating the whole person as opposed to just treating the liver itself. Next slide. And so really these type of treatments are geared at treating the metabolic syndrome and all the components of that to treat the whole issue that's going on. Because as I mentioned, most people with fatty liver disease are going to die of heart disease, not of liver disease. So if you have a therapy that treats the person holistically, the idea is you're going to improve their outcome, not just a liver outcome, but they're going to live longer from these other things. So you're targeting all of these components of the metabolic syndrome. Next slide. And so I'm sure many of you have heard of a drug called Ozempic. Okay, this is kind of the first big drug that came on the market that was holistically addressing the concept of metabolic syndrome. And the idea was that this drug does a bunch of things. And I'm sure if any of you watch the Oprah special, you'll have a good idea of how it works. And it's a very good special, I recommend it. It does a couple things. Number one is it acts on this part of the stomach, which the stomach is like a bag that catches all the stuff, and it kind of sits there, gets mushed up, and gets squirted out into our small bowel here. But if this drug kind of slows this emptying, so the stomach gets fuller, and people feel fuller. And that's why people say they get a feeling of fullness in their stomach, which is here. And so because they have that and feeling it's a little uncomfortable, they stop eating. It's like you've eaten too big of a meal. On top of that, this sends a signal to your brain. We normally, when we eat, we send a signal to our brain that says, okay, stop eating, right? So this Ozempic type drug, which is a GLP-1 receptor agonist, is the fancy name. It actually also sends that same signal to your brain and tells you that you're full. You don't want to eat, or you don't even want to go eat. And people forget to eat even with these drugs. So it has those two effects, and it actually causes about 10% of body weight loss. Next slide. But it also, how it's on the market is to treat diabetes, right? So it does that by weight loss, but also it increases insulin secretion from the pancreas, and it increases insulin sensitivity as well. So people respond better to the insulin that their body is seeing. So it's very good for glycemic control, which means it helps blood sugars. Next slide. But does it help the liver? Next slide. So again, New England Journal of Medicine, this is an older study, but they basically did a placebo-controlled trial of daily injections. Semaglutide is just the other name for Ozempic, okay? Of Ozempic in NASH, non-alcoholic steatohepatitis. Next slide. And most people were sort of in this range of a BMI of sort of 35, 36, and about 2/3 of them had diabetes. Next slide. and they injected it daily. So most people who take Ozempic, it's weekly, right? But this was done daily because they wanted to see if it worked. And so what they did, so this is this inflammation in the liver resolution. You can see here's placebo, and then here's the different doses of Ozempic, and you can see there's quite a marked improvement in the inflammation in the liver. Next slide. And if you look at the scarring is probably less. There is a reduction by almost half, 40%. But it wasn't significant because in this study, the placebo arm was 33%. So these are people who got no drug. The scarring improved in 33% of them, which just tells you a lot about what you can do with not even treating pharmacologically. Next slide. But it also tells you that that's why you need a placebo arm. If you look at the resmetirom study, the placebo arm was 14%. So if it happened to be 14% in this study, this would be a huge difference, right? But it wasn't. That's just the way it is. So obviously they're very interested in pursuing this, and now they're doing another study where they're doing the weekly injection like you would normally get if you took Ozempic, from your family doctor now. Essentially, the bottom line is that these drugs probably have a little bit of a liver effect, but a lot of the effect seems to be related to weight loss. Okay, so people lose about 13% of body weight on an Ozempic type drug. Next slide. But metabolic syndrome it affects the whole body, right? Like we talked about. So the question is, do these type of drugs affect the other systems that are affected by the metabolic syndrome? So next slide. And so the two big areas are heart disease, heart attacks and death by heart disease, and stroke, and kidney failure. Those are both increased in people that have metabolic syndrome. So the question was, do these drugs actually improve those outcomes? Next slide. So this is the holistic component, right? And so they showed that this study was a little bit older, back in 2016. They actually showed that an Ozempic drug basically improves cardiovascular outcomes, so decreases the risk of death or from heart attack or stroke in patients that have diabetes. But then people are saying, well, that's just related to diabetes control, right? So next slide. So this just came out in December of 2023, again in the New England Journal of Medicine, where they looked at the outcomes in people that had obesity without diabetes to see if it had the same effect or not. And it was called the SELECT trial. Next slide. And what they showed was over these 48 months of the trial, the Ozempic type drug is in the yellow bar, or yellow line, and the placebo is in the blue line. And you can see they separate almost immediately, and they keep separating, right? And this is 8,000, almost 9,000 people. So that's a 20% reduction in death from heart attacks, strokes, cardiovascular morbidity. And so no trial in heart disease has ever shown that kind of improvement. So that, after this study was published, that drug was approved, has been approved by the FDA now to treat heart disease. Okay, so this is in people that are living with obesity, right? Not just diabetes. Already been shown to be beneficial, and so this was, on every news channel you could be, because this is like when you talk to a cardiologist, this is shockingly different, even though it looks like they're just separated by that much, right? Next slide. So what about chronic kidney disease? So they started a study they called the FLOW study for kidney disease. Kidneys obviously make urine. And they looked at people that had type 2 diabetes, and they treated them with semaglutide or Ozempic. And this was just published in May of 2024. So this is all very, very recent. Next slide. And again, you can see, just look up here, these lines are separating. This is a 5-year study, but you can see it doesn't go to 5 years, it goes to 4 years. Because they stopped the study because they felt it was unethical to continue it because this improvement was so great. And dialysis shares of the companies that do dialysis in the United States dropped precipitously because this was going to impact the bottom line, right? So this has a hugely beneficial effect on kidney disease. Next slide. So you're starting to see how now you can start to how you can piece together treatments that are personalized. You can sort of say, well, this person has a lot of scarring, so I should probably have a treatment that's going to treat the scarring, but I want to treat their metabolic syndrome, so I'd like to use something that helps not only their liver health, but their heart health, their kidney health, and there's even studies now that have shown that these type of drugs are probably beneficial for Alzheimer's disease, so people are treating Alzheimer's, like they're quite interesting drugs. They have these broad, holistic effects. Next slide. So what's the next step? Well, the next step is you take this is like an Ozempic type drug, and let's stick stuff on it. So they're sticking other stuff on it that does other stuff that might be beneficial for weight loss or controlling sugar. So this GIP one, we're going to come to it right now. So next slide. So there's a drug that's called tirzepatide, which is released on the market now in the United States. I think it's just coming to Canada for weight loss. And what you can see, so tirzepatide is one of these super Ozempics, okay? It's got this GIP thing stuck onto it, so it has two effects. And what you can see is this is weight loss. These people are losing 20% of their body weight in 72 weeks. Like this is a massive weight reduction. Next slide. And so they're actually, just at the meeting that Mike was saying about, I was at the same meeting in Europe. It's this European Association of the Study of Liver, and they actually looked at the liver effects of this drug. And what they found, and again, this is only a phase 2 study, so this is not the phase 3 study before it would go to market. But basically, that the scarring, well, the inflammation improved by about 40%, and the scarring improved about 20% compared to placebo. So these drugs are very exciting with regards to another tool that can be used to treat people holistically, I think, for this issue. Next slide. So as I mentioned, I think treatments are coming, it's dramatically changed. You can see this is over the last 6 months, right? These are all coming out in the best journals you can get in medicine. And essentially what they're showing us is that we can start to treat these fatty liver disease with scarring differently in different people. We can start to fine-tune things to really help people in the best way possible. And some people might just be, switch from pop to diet pop, and that can make a huge difference, and that's all they need. Some people might need a drug like resmetirom, where it's actually targeted to get the scarring to go back, because weight loss is not such a so important for them. And other people, it might be a combination of the weight loss and a liver-targeted drug. And so you can start to, this is called personalized medicine, when you start to, everyone in front of you is an individual, you're not just treating everyone the same. Next slide. And that's it. So basically, I think if you go back not even that long ago, if you were given a diagnosis of fatty liver disease with advanced scarring, there was very limited things that could be done. And things have changed dramatically in a short period of time. If you go 2 or 3 years from now, it's going to be amazingly different. So I think there's, even people that have advanced scar, even cirrhosis, I think we're going to be able to treat them very differently in the very near future. Thanks.